All right. Bismillah Rahman Rahim. Dear participants and very eminent speaker, I welcome all of you to Saudi Society of Medical Education webinar series, Riyadh office. I'm Dr. Shazia Iqbal. I'm chairperson for continued professional development activities at Saudi Society for Medical Education, Riyadh office. And I can see that right now 21 participants are with us, which is a very good number for us to begin with. And we started this series with EPAs. Last webinar was also on EPAs, and we talked about challenges to introduce interstable professional activities in postgrad medical education. And I'm very much pleased to announce that today our topic is related with EPAs, and especially we shall be talking about how they have been implemented in postgrad program in Saudi Commission for Health Specialities. And I'm very much honored and to introduce you our eminent speaker today, Dr. Ali Al Yahya. Very warm welcome, Dr. Ali Al Yahya, to SESME webinar series. And Dr. Ali Al Yahya, he is consultant pediatrics and adolescents pediatric surgery. He is head of pediatric surgery at King Faisal Specialist Hospital Research Center. He's also chair of Curriculum Review Committee at Saudi Commission for Health Specialities. He's master's in medical education and FRCS. So with his credential and abilities, it will be good for us to know his experience, journey, and reflections, challenges related to implementation of entrustment EPAs in postgrad medical education. So today's topic for webinar is entering a new era of entrustment, especially when we are moving from traditional assessment method to entrustment. So very warm welcome, Dr. Ali Al Yahya. And now floor is yours. You can start with your presentations. This session will be recorded, and by end of the session, we shall share recording with all participants, and participants can keep their question in chat box by end of presentation, or raise your hand by end of presentation to ask question and involve in discussion. So I shall be keeping eyes on chat. I shall be moderating this session. Very warm welcome, Dr. Ali. You can start.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for inviting me to present this topic, which is an exciting topic for all of us, and hopefully it will be a good lecture, and hopefully we'll learn all from what we prepared. So my disclosure here, I want to disclose that I work as a chairperson for the Curriculum Review Committee in Saudi Commission from 2019. I involved in designing, writing, preparing the EPA from phase 1 to current, and I am honored to have that involved and present most of the workshop. I attended a couple of online.
Sorry, Dr. Ali, if you can make your screen slides on a full mode slideshow, because currently it's small size, so you can make it full screen.
Let me stop sharing.
You can make it on full screen.
Yeah, let's stop sharing first of all, and then. How can I?
You open up your presentation and go on slideshow and make it full screen.
Yes, thank you. Slideshow, and then full screen.
Yes. Right now, it's not.
Yeah, now I'm not sharing now.
You should share your presentation, because right now we cannot see your slides.
Yeah, but I need to put it as a not. How can I go for slideshow, and then I have the presenter view, play from current slide, and then play.
You can make play from current slide, and it will pop up.
And then I will share now, and tell me if that's okay. How is it now?
Yeah. Yes, it's perfect.
Okay.
Yes.
So sorry for that, but this presentation is a continuum of previous workshops and presentation that done by Saudi Commission to familiarize the educators, the trainer about the future plan and Saudi Commission training. Permission with great support was taken from the executive training department in the Saudi Commission to use and present the national process to establish the APA. Objectives for this topic today, I'll try to compare the competency-based medical education versus EPA. What is the difference? What is the similarity between them? Hopefully it will be a short review and then we'll go through it. EPA definition, specification, how we select them, and entrustment method. Our methodology for developing the APA-based curriculum. Let me start with this slide that always in any workshop or presentation by Dr. Samil Haider, he put this presentation and he said that we don't want to create textbooks residents. And this is give the impression that the one who has high knowledge, previous impression that the one who has high knowledge, more knowledge, is a better doctor, which is in fact is not the truth. And the thinking was internationally distributed, and from all time and since 1978, the competency-based training was described. But for a period of time, the people, they did not apply it, and they think it's very difficult for application until 2000, when CanMeds or ACGME or Tomorrow Doctors from 3 different countries, they start to think about the competency and the important to train and assess the trainers in different competency methods. Even national in Saudi Arabia, in 2017, we started to what we call Saudi Meds, and hopefully we will build on it a good competency-based national program for us. Why all this happened? And I think because the dissatisfaction of the quality of care that the trainer they provided, the training methods that we apply is not standardized, and the supervision was not ideal to which one you focus on, what you need from your graduate, what is the end point, and when you end it. And before this all, you care about the patient safety. And competency-based medical education, it is an education, and that's the terminology for that, aim to standardize the level of proficiency for all graduates. So we have a proficiency level that they have to reach it before they graduate. And it could be, there should be a clear description for the standard that you want the graduate to be, assessment of all medical trainees using these standards, and you cannot graduate them until meet it. Competency is not time-based, it is when they reach it. And that was the key point here, that you should think about competency. It is dependent on when they achieve it, is not the time-based for competency. And you look, it is very detailed analytic framework. And if you look for CanMeds, you have 7 roles, and under each one of them, you have to deal with different aspects until you reach for each of them that it's breaking to a different categories. So they end with Canadian CanMeds with 700 competency component and milestones, which is huge number if you want to evaluate a resident during his training for the 700. An application, it will be very hard to apply it. And when they start, they hear the radiology progress test in Dutch, Netherlands, they measure the level of progression of their resident during the progress test. And they found there is a good progression in their trainee with time, but they set a line, and they said this line, anyone above it should be competent, we call competency, and anyone below it, he is not competent. And the aim of this line, that if anyone from level 3, he should be competent to pass the exam, and he should be a competent to be, in their criteria, a good radiologist. Anyone who is below it, they will be going to see and evaluate them, and they are at risk, and they try to find what is the reason for them to be lower than the standard. And this question is coming to all of us. Are our graduate residents ready for practice? Every day we are asking ourselves this question. Which usually when in the literatures, there is a lot of literatures written about this. And in the US, they talk about the resident readiness of graduation. And there was a query from most of the program directors about the graduate, and they are not all, or universally, they are not ready for independent practice. And they have a question about the autonomy during their training that limited their readiness in practice. On the other hand, they looked for what is the reason for this failure. And questionnaires sent to the European program directors, and many of them, they can recollect at least one case that they think that the trainee is not ready to practice, but also they signed him off for practice. And they failed because either the time is up and they cannot catch with that, no valid documentation in the back up to fail them. So they cannot fail them now because they don't have documentation to stand on and they say you cannot pass. They did not warn him before or correct his deficiency in training. They are worried of the failing of training, give us trouble, they complain, and then they will go, they put the program under preparation, and they have to pass 30, the failure rate should not be exceeding 30% of your trainee, and so they don't want to go through this process. And also, one of the most important things, you don't have tools to handle this. So basically, you may not prepare from beginning to catch the weak resident and put them again on the right track before they reach the final year. And I believe if we allow somebody to reach the final year, it's a failure of us to graduate him. If he's not competent, not failure of him. And if you reach to not sure if this patient, if this candidate is ready for practice or not, always we go for the benefit of trainee and give them the sign-off papers. On the other hand, do the resident feel ready for practice after graduation? Even the resident themselves, they look to them day one, and there is systematic review that looks the opinion for all the graduated residents, mainly in surgical, general surgery residents, and they found that they feel not ready to practice, and they have low confidence in themselves when they start practicing in their first year of practice. Why this? I think it is because it is the balance between the autonomy and the supervision. We have to supervise them to be sure that there is a patient safety, which is number one. And then we have to be sure that we have an excellent outcome. We care about our patients. We need to give the patient their satisfaction. He wants the good trainer to operate in him or to be there. And on the other hand, we have to think about the autonomy for the resident. It is part of the education. it have to give them satisfaction, confident in themselves, so they will be ready, and it will not be strange environment when they practice. And personally, I think it is different, even simple operation for me. It was different in my first few months in practice from my training. Decision making also in the first few months in practice, it was very, very difficult. Diagnosing acute appendicitis, it was hard for me in my first months in practice. And I think it's coming back because the balance between the autonomy and the supervision. And this is where the competency framework starts. It is accepted worldwide. It is very detailed. That's the problem, really, that you are having a lot of details. It is a competencies, so we think it's competence, and it can be a generalized judgment. It is the main thing is the application. Clinical teacher, they cannot assess every single competency they need to assess. And Oli Cates, in his course and also in his presentations, he collected a couple of papers that they are criticizing the competency framework. And they think that the graduate here is not they didn't graduate a competent, they graduate incompetent trainer. So simply, I think because there is a gap between the theory and the clinical practice, how can we bridge this gap? And if we answer this question, I think it is great by theoretical application. If it's theory, and if we can gap it, then it is very, I think it will be very good to be applied. From that, they came with what we call the entrustable professional activities. Why we don't break these competencies to small pieces, build them one by one, take what like in a building, you cannot build it as a one piece, you have to go one by one until you reach a full nice building. So it is a unit of professional practice, what we call task, that may be entrusted to a learner, that to be done unsupervised. When they demonstrated required competency, and that's why you are going to converting from looking for a large group to a small task. You are going a task, not the person itself. And this is what is the difference between the EPA and what is and the competency-based, like the CAN-MIDS now, current CAN-MIDS. You are evaluating a task, a job. You are not evaluating the person itself. I trust you to operate on common surgical procedures in pediatric surgery, but he may be not yet trusted to do a complex procedures. Here, this is the milestones by the CAN-MIDS, and this is in Saudi most with agreement that we achieved to take and utilize it in our building EPAs and milestones. So we agree with them to use the milestones in this edition. But let me explain this page, which is you are all familiar about it. This is the stage of training. They have 5 stages of training from entry to residency until they are advanced experts. After discussion in the project team, we decide to go for induction, junior, senior, and to not use the advanced expert, use it as a CME hour later on, or use it as something that in fellowship programs. Here, the role itself, this is what we call this one key competencies, and this is the enabling competencies, and these the milestones. So EBA, it's basically collecting different milestones from different enable competencies that represent a different roles. So if you do it all together, you get the one EPA. So you can trust in one task, you can trust your trainee in different roles, in different enabling competencies with different milestones. And this is what you will get when you write your EPA, and after that you get the domain. And under each domains you have the competencies, or under each competencies you choose which milestones you want. So this is the network or the net shape of the EPA. Here is a map of between the roles and the EBAs, and give you in medical experts, you will use it in how many, 3, 4 ABAs, but in leader or scholar, you need it more, maybe less, which is only for senior person. Professional, maybe you need it for 3, the other one doesn't require. Here you can map your ABA to the roles. And after that, this is where you build your assessment. Your assessment will be focused on the ABAs itself and what roles they are doing with enabling competencies. Basically, ABAs in the curriculum, it is like the run each one, give it to the one front, and then we will go from one level to another level, one level to another level. Hopefully, you take your trainee from novice trainer to be a competent trainer. What is the specification of good APA? And honestly, there is a lot of changes. You can see here that published initially 2005, modified 2015, and then 2017 to have the specification for the APA. It has to be essential professional work. It's required knowledge, skill, attitude. So you cannot do it in one learning domain. It has to go to recognize output, usually to be done by qualified person. Medical, you do it for medical, and people who is in other specialty, done by other specialties. It has to be independent from other APAs. It could be done, it should be done in one, it should be done in one, in a time frame. So you cannot exceed that time frame. It is observable and measurable. And this is very important, that you can observe them and you can measure it. And it leads to conclusion that you've done or not. It is reflecting on more competencies. In 2021, it was 8 criteria, now it came 10. And the change is not much really, but they both, it should be specific and focused. They have to specify what you need from them, either one competencies, it has to be specified competencies. So, and focus on certain tasks that done for them. And also they changed that, they added how do you write it. It should be written in a way that describe task. So continuum verb is the used type. And we will have, I will show you how the good and the bad written APAs. So it has to be written in a good, to describe a task and continuum verb, so you can measure it. You should try to avoid adverb and adjective. There are 4 things you have to do it when you think to build an ABA curriculum. Number one, what do you need? So when you start to build an ABA, what do you need from your trainee? Okay, I need him to be adequate to, for example, in one of the specialties, to do an intubation for the patients. So this is the question. It is a specific question for an ABA, which is acceptable if the competencies and the role under it is measuring multiple competencies. Or it could be broad. I need to build an ABA that I could trust them to manage a common pediatric surgery problems. So, and then I will build the competencies, and I will build also on them the knowledge about the common and the skills, the knowledge and the skills for the common pediatric surgery problems. And this is what we call nested competencies. Like if it is one ABA and there are multiple small ABAs inside it, this is what we call nested competencies. What you need them to demonstrate before you trust them. This is the second thing, and you have to make them ready for the trustment by make everything required for them to learn it available. Before you entrust them, you have to be sure that they have enough exposure, they have enough education, teaching, and you go through them with multiple sessions before they get trusted. And this is very important in building, which is number two, in building the ABA also. Anything need to be prepared to meet this requirement. Like if anything you needed from previous training, anything you need them to be prepared, that you prepare for them now, like if you are you're going to take them to the simulation, or you need them to be inside the workplace or outside the workplace, and you have to be sure that the trainee understand the component of each ABA. What are the required things from them before and during and after the ABA. Finally, which is still, at least in Saudi Commission, an area of discussion, how do you assess the trainee? And then using entrustment scale is the standard, and that's what we use or we agree to use for assessment. When you think they are ready, then you have to put them that it's entrusted, and then you sign them for this ABA. In one of the discussions during our building of ABA in Saudi Commission, there was a question about what is the ideal number for ABAs for each program. And actually, there is no predetermined or recommended number in the literature. The total, we thought that 10 ABA per training year is adequate. Like is what we aim to, maybe 8 to 12, but 10 is the adequate number that we focus on the training. And the question will come, is 30 or 40 ABA enough to graduate a pediatrician, family medicine, surgeon? If we use the nested and the continuous, and that's for answering that the undergraduate ABA, the continuity of ABA from undergrad to postgrad, I think by the time they came and involving the nested ABA will be enough to trust them. And that's why we recommend to cluster the small task and the small ABAs in one large ABA, so you can catch as much as you can from your current curriculum. People who work with us for the last few years, they remember the discussion about the specific ABAs with them, how many meetings we conducted to approve it for them, because we think, if you are specifying each problem in your discipline, you will end with hundreds of APAs. Okay, so here I will give you some common misunderstanding of the APAs. If not discrete task or not suitable for focused entrustment decision, example for that, demonstrating professional behavior, you cannot trust them in this. You cannot entrust them in this. You cannot, it is not discrete, it's wide. APA that are confused with another APA. If you have two APA, like managing the sad patient or sad child, recognizing child abuse, I think they carry the same meaning. APA title specification that sound like educational objective, evaluate, manage. That's why you should use continuum verb, managing, demonstrating. It's better for writing the APA. APA that include adjectives that for proficiency level that's very hard to measure, skillfully or safely, efficiently. You have to performing common critical care procedures. Very difficult to know what's the meaning of safely or efficiently or skillfully. So try to avoid it in writing your APA. The APA that are too broad, it's very difficult, like care of acute or new patients. It's for what, which aspect? It's very difficult to be trusted for a broad APA. APA that are in the opposite, discrete task, but not suitable for entrustment, personal development plan. And in Saudi Commission, we thought to be away from the number one, the task that's not suitable for entrustment, and the discrete task, anything related to research, anything related to behavior that will be outside our scope currently from APAs. Yes, there will be milestones for proficiency level, but it will not be a full APA that can scholar or behavior professional development of the trainee. Now, how we assess the trainee using the entrustment decision for APA. When professional activity is mastered, that means you reach a threshold of learning. You can trust them. Now it is the time to permit trust to them, and they can act unsupervised in practice. And this is a stage of development. And if you look here, this is the scale of entrustment. Observation, they can observe you and you trust them that observed. They can do with direct and proactive, you do it with them with direct and proactive supervision. Then they can do it with reactive supervision. You can supervise them from distance. And then finally, you can provide the trainee, they can do it while you are not supervise them, and they train another trainee. Here is the same modified by Ottawa, but make it easy. I had to do it and watch me. I had to take them through it, and this is your comment. I had to direct them during the procedure. I need to be available in case they need it. I don't need to be there, and they are competent to do it. Here, the same slide for what we about mapping your milestones, and each one here, what is different with years progression, the level of observation should change. What you trust them in R1 should not what you should trust them in R3. So maybe it is the same competency, the same ABA, but the trustment scale is different at this stage. So people, they grow with time. and you expect them to go from novice to proficient. And when they reach the competent, they are ready for practice. But still, they have time in their practice to build themselves. Graduation is coming when they are competent to do things, then they are ready for graduation. So that means they are ready for this supervised practice. But if you look to two different trainees, usually they don't reach the competency at the same time. So do we need the 3 years of family medicine program, 5 years of general surgery programs, or it is trainee-based learning? Some people, they will stay 7 years. Some people, they will graduate in 4 years. Some people, they will graduate in 3 years. And that's because our nature of training, they are different. If you look to one APA for one trainee for several APAs, also they can catch it in different levels. They reach the competencies for some APAs earlier, while they are not able to catch the other until the end of their training. And actually, some of them, they may lose the trust if they did not practice it. And this is the importance of continuous medical education after graduation, because then you may trust them to do one APA because they lost practice in that APA, then they lost the confidence. And now it came the question, the big question for the APA, is there a limit, a time limit for your APA trust? So when you trust them now, that means they are trust forever, or they need to redo it after 2 years or 3 years. There are two methods about ad hoc and summative entrustment. Ad hoc entrustment decision that happen every day. Good thing that it is done, and it's the commonest method to be done to evaluate APA, but they have a problem with it. That's why Oli Kate, in his articles, he said it should be a summative entrustment, and he make an example of driver's license. You train them, but one day you have to entrust them with summative exam. And basically because the ad hoc is affected by many variables, like, they are today with somebody who is with them, the case, they can help them, the context around them, with the people around them, they can help them. No useful to, the problem of it is not useful to try to arrive reliability. If you repeat it, it may not give you the same result. Trust him now, but maybe after 2 or 3 weeks, then it's not the same result. But on the other hand, the good thing about it, it is something you trust the trainee on a specific thing, and it is reflect the workplace. You took him to a workplace, and it's reflecting the workplace. How many you need? When do you need to repeat it? That will go to overcome the downside of the ad hoc entrustment. There is no long-term consequences. You can repeat it until they get trusted. There is rapid reflection, and this is the most important thing. They are the best place to reflect on them and correct them, simulate development and evaluation of trainee of readiness for the summative decision. And they put this one, if you decide to use the summative, at least you simulate for them what will happen in the summative assessment. While the summative decision, it is documented, it is a higher level of responsibility, and you can recognize it can be done by a third party. They did not go with the trainee during his training, and you can judge on it. Is he ready or not? The problem that they agree at the end, and what if we use multiple ad hoc decisions, we gather it together and we use a summative decision. This will replace the real summative entrustment or not? That's still a question to be answered. It is a it should be a multi-source decisions. And you need to collect all the data and how you progress it. And then after that, you make the decision. In Saudi Commission, again, I'm honored to be one of the 4 people who start here with Dr. Nihal, Dr. Sami, and Dr. Sami Al-Haidar with under supervision of Dr. Wissam Abu Znada to how we can through it. And that's why I chose that. This is the conference that or workshop that presented in it. So we started with them about the job task analysis, what the graduate of the program are expected to do from your program. What do you expected the graduates to do when they graduated from your program? And they can find the answer of this question by either reviewing the published literatures, nominal group technique, they nominate the scientific committee or council, they nominate some good educators in their field, so they choose what they wanted, or professional guidelines, if there is any guidelines, so we need them to know the guidelines and you use it. Prospective logging of clinical practice of work, you come in the morning of 1 week and then you say, okay, I'm now going for my work. Anything that can be an EPA, I will write it, and you choose 5, 10, or how many of them, you choose them, and at the end you collect what they sent to you to be an EPA. After that, after the job task analysis, we found 8 or even, which is mirroring what is in the literatures, that there's 8 tasks that should be examined or should be used as an APA. Assessment, emergency or urgency conditions, performing procedures like either basic or minor, managing patients, and this patient, is he complex or non-complex patients? Is he stable or unstable patient? Performing an operation for surgical specialties, provide consultations, formulate discharge plan, and counseling patients. We validated the process through the Dolphy by the project management team with the R4, CRC, which is the curriculum review committee, 15 members, national trainers with 55, and the residents at 37. And that's the result. Most of them, they agree about it, and that most of them is applicable to their program. And then this is the 3%. When we dig in it, we found that most of the people who apply for the questionnaire, they are not surgical, so that they think its surgical procedure is not suitable for their program. And from there, we end by having a general, or we call it generic APA, Saudi Commission generic APAs, divided on 3 phases: induction phase, which is 3, and then junior phase, 7, and then senior phase, which is 10. And this is a generic, could be used by most of the programs. It's not the only APA. Any program has the right to write his APA. He can use one of them and then modify it to his need. But this is a generic that we thought that it can be acceptable for all programs. I was also involved in a process how we select the checklist and mapping, how we do the selection process and mapping process of APA. And we did a review over a small group with Dr. Sakra Balhar, Dr. Nahla Ali, and Dr. Saad Al-Mani. We did it, and we end with this form that it's there for what you need to select. So either the APA selected, it is from the subcommittees of the scientific committee of the program, and then is it trustable or not, it is measurable or not. Then all the questions that we find that it's needed to be in the APA, we use it. Educational value of the APA, also we include it in our work, and how we validated the process, that is through the trainer themselves, through the trainee, and also the scientific committees. After that, the program, he will map the ABAs on to their rotations, and which rotation ABA you can find that, for example, ABA for junior, it's going for 4 or 5, 7 rotations, and they will start from any one of them and they continue on the others until they get trusted in this ABA. Now back to this, because the milestones now is very important. How did we choose each ABA milestones? And this is another process. Now we choose the APA, and like, how do we choose the APA milestones? And if you look for the colors, the developer of the milestones, or he check on what he think this is an APA. And if you look here, the advanced experts, there is no APA from the advanced experts because we already decide that the advanced experts is outside our scope. And then we get to review it. So we have 2 other colors. One color is related to the developer itself, that he thinks this is important, but maybe I will not include it, I will see. And the other one, it is by the reviewers who think this is an important and need to be informed. And we get this map to know how many of the medical experts we used, how many of the communication milestones we used, and for all the milestones. And then we get to discuss between the developer and the reviewers why we did not select these milestones, why we did not choose the unselected milestones. And we came with this view that medical advanced expert is not included. The whole enabling unselected enabling key competencies theme is not used, like the CAN-MEDS. Milestones can be measured by another milestones, which is higher in the level of competency. And we use the theme of suggested milestones. We look to the suggested milestone by the developer, and we look to the suggested milestones by the reviewers. And we open it and discuss each one of them separately, and we get multiple feedbacks and multiple meetings until we end with the final decision between the 2 reviewers, and then get it to the other 2. So we are 4. So after finishing with the 2, then we go to the big committee, and then we discuss the finding, and then they get the conclusion from there. Anything still debate, people, they will vote for it. And now we have end with this shape with the our APA, like there is an APA scope and then the milestones under it. And this is one example of generic APAs with its milestones. If there is time, I will tell you just in one maybe slide how you get the APAs from your current curriculum. You should review your list of APA under stage of training, and we advise go to the generic APAs, review it, and then match it with your program. Match it with the role and the responsibility of the residents. Do you think they meet? Is there anything that I can use for them in the program if I look to their responsibility, if I look to them? And then after that, if you selected the APA and you agree about the APA, go now to the milestone matrix and go to the key roles, enabling competencies. It is in your curriculum. Look for it, because our curriculum, most of them, or not, nearly all of them, they are a competency-based curriculum. So you'll find it in your curriculum. Go there and try to match it with suitable milestones in that APA. And if you could use it, yes, use it. You could select what is in APA that's chosen from CAN-MEDS. You can select it from anywhere, and you can write any milestones And this is another process. If you write milestones, it has to be approved to be sure that it is progressive, but you can use what is in CanMeds and you can use from any other sources. This is the prescription card that you write your APA or the draft of your APA. Here you will complete draft of your APA, and then after that you modulate it according after discussion and the need. Please ensure there is a logical progression for the trainee. You cannot start a higher competency before the lower competency level. And with time, try to make it a short number of, increase the number, decrease the time for observation, and to give more feedback to the trainee for coaching. Please check the accreditation for your standards and your program. And this is very important. You cannot build a curriculum which is not on your standard of or accreditation. So that's one of the very important method that you should do it when you look for your program, and go call the scientific committee, check with accreditation, what's your standard for accreditation, then build your APA. Before you launch it, it's very important. You have to educate the people. You cannot take it and throw it in the ground and let the people do it. Otherwise, we will fail, similar to what happened to the CanMeds. And we will not answer the question. Please allow time for development of the teacher. And I think here, coming the importance of the TOT programs to start to talk about APAs and the application of formative assessment and the APAs to make people ready for the next next era of competency area. Make sure that you all, with the support of the scientific committee, that you have the agreement, and make sure that the assessment needed for your trainee is ready, and then launch your program. A simple dynamic, it is an area of improvement. It is an area of improvement, and it is an area of improvement. So what is in 2017, it is changed from 2020 and 21, and prepare for the new update, and then make changes that required. Ensure that you are online with the other people in the APAs. And this is the challenges that we gone through and we managed, and some of them still, we will go, inshallah, through it. How we inject the APA. Is it a stepwise or practical approach on a curriculum itself, or it is a full curriculum? It is one center or multiple centers? How we make it? Khalas, we will take family medicine, for example, they are all ABA, or we have to pilot it in some centers. How we validate this national framework? We have to look for a pilot study with them in practice, and what is the obstacle they face? Sit with the people, stakeholder, listen from them what the obstacle they found, and then go back and revisit our APAs. And also, it is the assessment method. Should we do it formative, ad hoc, daily assessment, or should we do it with summative? What is the bylaws of the Saudi Commission? Do we need to change the bylaws of the Saudi Commission before we launch the APA curriculum? So in conclusion, the APA, it is an increasing curriculum, and it is worldwide. Start people, they want to apply the APA, but in fact, the practical application, it is running in very lower speed. And this is because the obstacle they faced, and we learn from our experience, we learn from the other experience. Hopefully in the coming years that we'll go through it. Authentic APAs is very important because you give them the workplace and then you require a good outcome, and you can trust them on the APA. APA title should be written in very good meaning, but it doesn't mean it gives you what's inside the APA. An example of that, performing intubation for stable patients. It's seemed to be one task, but if you go to look for the milestones, what is under the APA, you see how many competencies they injected through that APA. Evaluate your program on regular basis, go to the stakeholders and learn from them what's the obstacle and correct it. And again, I hope we can bridge the gap between the theory and the clinical practice. And this is a word that's written by Oli Kate, who's the top leader of the APA, that the distinction of APA from competency keeps confusing educators. And he apologized for any failure to explain it enough in the past. So it is still a marathon, and we still to run together, still to apply it, learn from each other, help each other to reach an excellence of training. At the end, I should acknowledge the people who involved in the project management, for the administrative team that work with us during our project, for the curriculum development team, for the 8 specialties that we choose, that I personally learned from them during the meeting with them, during the workshop. Every time they ask questions, and we look for the answer, either with literature or to find an answer with them, and also from the courses that provided by Oli Kate to familiarize the people about the APA. Thank you.
Thank you so much, Dr. Ali Al-Yahya, for this wonderful presentation, and it's extremely informative, especially the way you have explained how you implemented and what kind of challenges you face. No doubt it's a matter of great teamwork, and it's a matter of time to establish EPAs in postgrads. So I will ask participants if they have any question. Please feel free to unmute, and you can raise your hand and can ask question, or feel free to write in chat box. Any question?
Dr. Shazia, can I ask a question?
Yes, please. Sure.
Thank you, Dr. Ali. I really enjoyed every moment of this talk. I have questions regarding the EPA. In one of the slides, you put some people, they finished the EPA early, some people on time, and some people they're a late achiever of the EPA. My questions, can we categorize this EPA that the trainee must finish it before proceed to the next level, or we can make all the EPA the same? So a trainee maybe is unable to finish 1 or 2 EPA, but still he can progress to the next level. Is there a APA that the trainee must and have to finish or complete before you proceed to the next level, or you deal with all EPA the same?
Thank you for this question, and I think it is coming to the under the assessment. To be graduated from one level to another level, you have to finish all the APA in that level. From induction to junior, you have to finish it. From junior to senior, you have to finish it. And then to graduate, you have to finish the senior. The question on the slide is showing that even reaching the junior APAs, they are different. You may give them a framework in your program. You choose the induction phase 3 months from start. But some resident, he requires 6 months. So he will be late in his training 3 months. You expect he will be late in his training 3 months. So they have to finish each EPA before they go to the next step. or the next level of training.
Yes, Dr. Hamza.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much for really very comprehensive and very complicated talk with very simple presentation. And I think everyone enjoyed that you're talking and so on. Yeah, I was just looking for assessment. That's how really hard work you have done, you and your team, to really come up with these tasks and milestones. And so from the 7,000 milestone in that one, it was summarized really in our all programs within 10 APAs per year and 30 to 40 APAs to really complete the job. That's really excellent job. Congratulations. But coming to the assessment, as you said, that ad hoc versus the summative, and you said very clearly in the beginning that if someone is failed at the end, at the summative, so this is our fault, it's not the trainee. So what you have done really, that ad hoc assessment is going on. So are you really entering into the programmatic assessment and really collecting the all things, and then they are in each year, they know that the task which was really given them, as how you're really comfortable with the trainees, that they are really interestable that a particular period. Thank you very much.
Thank you, Prof, for your question. And I will say it simply. We think this is what will happen. The ad hoc will prepare the trainee, you daily basis assessing him, and then you do different methods of assessment until they are trusted for that. But in theory or in practice, I think we should wait to see what is the people on ground face. This is really the right way of doing it, and at the end, will graduate a competent trainee for us or not. I think it is with the pilot, we'll see the difference. And there is proof from other places that if you do the ad hoc every day and then you give them repetitive feedback, they will learn, and by the end, they will be okay for the entrustment. But in practice, we did not yet reach there, and hopefully we will learn from the development team as soon as they applied.
Thank you. Any other question from participants? There is a lot of thank you messages from everyone. Thanks, Dr. Mansoor, to share PDF and link for the courses if somebody is interested in EPAs. Thank you, Dr. Mona, for joining. So in chat box, there is, yes, Dr. Hassan Al-Zahrani.
Assalamu alaikum wa rahmatullah.
Wa alaikum assalam.
Assalam wa rahmatullah wa barakatuh.
Thank you very much, Dr. Ali, for your nice presentation. Thank you, Dr. Ashazia, for nice moderation. Thank you for all participants. Honestly, we are very proud of the organization that takes care of postgraduate training in Saudi Arabia. Saudi Commission for Health Specialty, people working to improve training, to reach the excellence in training. The presence of good people like you, Dr. Ali, Dr. Sami Al-Haidar, Dr. Wissam, we are all proud of what you are doing. And really thank you for what you are doing. And we wish all the best for the project that you are working on now. And from our side, from SSME, Saudi Society for Medical Education, we are going to work together. We are taking, inshallah, the medical education to a next level, and we'll work together, inshallah ta'ala, to improve the training, undergraduate training, postgraduate graduate training in the kingdom. And we hope that during this coming period, we are going to achieve all the objectives to get the benefit and the wishes that we want to have it implemented in this time. Thank you very much again for this nice presentation. Thank you for Dr. Ashazia. And inshallah ta'ala, we wish future series all the success. And we are in SSME, Saudi Society for Medical Education. As I mentioned before, we have to contribute positively to the development of medical education, both undergraduate and postgraduate. Thank you.
Thank you, Dr. Hassan, for your nice work. And I want to congratulate you and your board for to be elected to lead this nice society, and thank the previous board for their great job that they did.
Thank you. Thank you.
Thank you so much, Dr. Hassan. There is one question in chat box I can see from Dr. Shehzad, that how can we progress to apply APA in undergrad medical education?
Well, this is really very good question, and I think with time, and I think it will come as a part of continuity of learning. And when they see the APA get more popular in the postgraduate, they will apply it. I really advise the people in the university to take it serious, because this is the new era. They have to start to build their curriculum on APA basis. And this will help us for the postgraduate training, because we will get the trainee ready from the undergrad. And there is a lot of literature about the undergrad APAs.
Sure. Any other question? Dr. Hamza is still having his hands up.
Yes, I have lowered my hand now again. أقول أنا أشكر الله سبحانه وتعالى أولا وجزاه الله خير Dr. Hassan and others, that really we are thankful for the all hard work was going on an undergraduate and postgraduate level. Just I wanted to share because yes, as you said, there should be continuum from the undergraduate to postgraduate. These are the all new era and the new things. People has gone very advanced, but we are working really. We are having a project, and I'm not sure the Professor Mahmoud is there or not, but at King Saud University College of Medicine, already our project is ready to be launched for the APAs in undergraduate. And we hope that within coming few months, and at least we will be able to tell our experience and journey, that how really we have gone through the APAs in undergraduate level. So yes, and I advise really all of us, really we think in this way. So we started as objectives and outcomes and competencies and APAs and tasks and milestone. All these looks now for us, it is a buzzword, but I think this has to be really adopted and going in and practicing. I have in my clinic usually during training undergraduate and postgraduate, but still and I can say that even the trainees, they have to understand well that what is needed from that and what their duty to really succeed in that. Thank you very much. Jazakallah khair.
Shukran.
Thank you so much. Yes, I can see that Dr. Sami Al-Haider, you can ask comment.
Yeah, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good evening. I hope my voice is clear. I'm using a new Bluetooth device.
Yes.
I hope it is clear.
Yeah, it's
Dr. Shazi and Dr. Ali, thank you so much for this evening. I think we had very nice and pretty much missed discussions. I think the expertise we have in our healthcare system and health education is really rich at national level to have this kind of scientific discussion. I think the Saudi Commission is trying to contribute, and I thank really my brother, my friend, my colleague, Dr. Ali, with his excellent presentation and reflection of the long, relatively long journey that started almost 2018. And we are still actually learning from this experience. And it is really massive experience to tackle as we are responsible in our mission in the Commission toward all disciplines in healthcare system. For instance, we are dealing now with 181 postgraduate training program that is distributed mostly in medical and surgical specialties. However, we have a very growing number of postgraduate programs, more than 9 programs in dentistry, more than 7 programs in nursing, more than 12 programs in pharmacology, and the same thing for applied health sciences. So I think the journey of transforming our way of training to the entrustable professional activity is going to be very challenging. I don't want to spend time on how to apply EPA in curricula development, because this is one part of the puzzle. I think, as Dr. Ali mentioned, there is still challenges to go over when it comes to implementation, and then to the ongoing phase of evaluating the implementation and going back and forth in improvement and quality checks. And I think everyone here agrees that curricula has been and will continue to be an active area of quality improvement. I don't think EPA is a total shift from competency-based. I think all of us appreciate that EPA is an next generation process of curriculum based on competency. In order to take this in national level, I think, and this is actually my message to the group here, we really need your critique. And we really need your advice and contribution. And really, I thank Dr. Hassan Zahrani and the current board of Saudi Society of Medical Education and the previous panel as well for the efforts that the society is making to create this community interaction. I think holding the conference last year after the COVID and pandemic effect, and now coming up with those evening medical education clubs, I think is going to make the venue with everyone busy schedule, so we can discuss openly and make our national capacity building. And I think at Saudi Arabia, we are really ready. Based on our expertise, Saudi Commission has been established for 30 years, since August 1992. And we have been through a very interesting learning curve. I still remember the days when I was a resident in a program and then being a chief resident in the Saudi board and then going over to different roles as trainer and then contributing with excellent group. This is a call for everyone in Saudi Arabia, in medical education, in healthcare professional education overall, to share their ideas and critique and support the national transformation, which is coming timely with the 2030 vision and transformation in our country. Now, I think why EPA, I think Dr. Ali touched this at the start, because it makes competency-based education more meaningful. And it makes competency-based education more practical and feasible for implementation, and even from the standpoint of project management, which I think education now is a business-oriented environment. And I think EPA is not going only to deliver the competencies to the trainee and the trainer, and this is one of the great strengths of competencies. I remember in my postgraduate education, when I was a resident in pediatrics, I was struggling to adapt the CAN-MEDS. I was very excited about it, but I was stuck with the wall of how to embrace the 7 competencies. I think EPA is coming with a very meaningful clustered professional activities that you can reflect in terms of teaching process, formative assessment, entrustment process, and finally the summative and certification, and giving the privilege and credential for hopefully your competent graduate professions. So I think there is no doubt that EPA is the way to speak medical education. Now, definitely there will be challenges. One of the challenges EPA is bringing a major jargon of scientific terminology that will be making a little bit of barrier between clinician and clinician educator and pure educators. And I think this is why we need this kind of activities to break the ice and make sure that everyone is familiar with what they are doing, though we are labeling it now and framing it with complex terminology, make it a little bit of barrier to them. And I think for educator and pure educator, we have also to be ready to speak a layman language, a clinician language, when we shift from our scientific discussion to the bedside education, where we have our community of clinician educator or a bedside or bench educator, where maybe not necessarily they are not required to have the full gear of EPA scientific jargon and terminology. I think EPA will bring more cost to train the trainers, at least in the transitional phase. I think it will bring also some liability and dependency on technology and informatics, and we have to be ready with our e-portfolios, our e-curricula to capture this transition.
Thank you so much.
We are hoping that our future graduates will speak this language, at this gap between this transition is going to be shortened. But I am really, again, I will conclude with my thank to the organizer of this meeting. I think we need to have this discussion and this community of educators and clinician educators to share the discussion and challenges. And I hope one day we'll have our also postgraduate adult learner among us to challenge the process that we are proposing. In order to take their input and their contribution. Thank you so much, Dr. Ali, thank you so much. I would like to thank finally Dr. Shazia, the team, the great team we have in this EPA project. We have Dr. Thuraya Qattan among the group, Dr. Mohammed Al Mansour, maybe Dr. Nihal Khamis not among the group today. Our administrator, Ms. Layla Yusuf, Ms. Budur Tuwaim, Ms. Lubna Al Majid, Najla Al Ajaji, and many, many others. I am afraid I forget some of the names. We have our National Curriculum Review Committee, which include excellent multidisciplinary clinician and healthcare professional educators contributing to this. It's again an open call for everyone to share, critique, and support to this national transformation. Thank you so much and have a nice evening.
Thank you so much. Yeah, thank you so much, Dr. Sami. I think you people are doing great job to establish something which is really very exciting. Very quick question. We are running short of time. Dr. Shahid Akhan, he has raised his hand. So quick question. Yes, please, you can unmute and can ask your question before we finish our meeting.
Thank you very much, Dr. Shazia and Dr. Professor Al Yahya. Thank you. Very nice presentation. Quick question. How would you differentiate the use of reference? When I say reference, I mean in your EPAs, norm referencing and criterion referencing utilization in your EPAs, please. Thank you.
Maybe I will ask. Maybe I did not get the question. معلش يا دكتور, can you ask? Sorry again.
Sorry,
Sure, I
doctor, can
can.
you?
Yeah, sure, I can. I can repeat myself, and I might go a little slow this time around because I thought it's your running time, short of time. So, my question is about reference. When I say referencing means in your assessment, the first slide that you showed it in the different disciplines, the curved line that you showed, perhaps it was your second or third slide. How do you reach to that reference? Is it a norm referencing or is it a criterion referencing in your assessment and APA? Because if you want to, equate and standardize and have quality assurance and have benchmarking, then you have to have, criterion referencing. How did you develop that criteria against which you are you are assessing your candidates for that? I hope you get my question.
Yes. Thank you for your question. And I think for our national experience, not yet we are reaching to see what's happened and see the curves. What I presented is the experience from the competency-based before and international. But for ourselves, I think with Dr. Thuraya Qattan and the people from the assessment, we're still conducting now multiple meetings to reach the decision how we assist them.
All right.
Last question, Dr. There's a question about internship. How do they apply for the
Yes,
internship?
Dr. Mona.
I think this is a very good question because the induction phase, the plan of Saudi commissioned that the induction phase to be done during the internship and will be general for all the internship. Future.
Thank you so much. I think most of the questions have been answered, and I would say now, thank you so much, Dr. Ali, for your efforts and your time. And thank you all participants for taking active participation into this session. And now I would say goodbye to all, and sure, I shall share this recording with all of you. Thank you.
Thank you. Thank you.
Bye-bye. Have a good night.
Bye.